So he asked me if I'd take the honor of introducing George. Obviously, many of you know George. George did his fellowship and his training at the Channing Lab here before going back to Boston University, where he's professor of medicine and director of the adult asthma program. He's been instrumental in helping us to understand better aspects of management and thinking about asthma, both from the epidemiologic point of view and the clinical trials. He has been involved in the Inner City Asthma Project for years. He's been a collaborator on some pivotal trials that are ongoing now, including one that the Channing Division of Network Medicine is involved with the vitamin D and the VDART study. He's been instrumental in looking at some of the information from the Framingham Heart Study and some of the valuable information we've seen from that from a population-based, and collaborates with colleagues over at BU both in informatics and in the School of Engineering and some very novel things. So we're really interested and excited to have George with us today to update us a little bit on the Inner City Asthma Study and some of the related work that he's doing related to asthma. Thank you, George.
Thank you, Ann. All right, is the sound working?
It seems to be.
I guess I can't wander around as much as I usually do in giving talks because I'm being filmed, so I'll try to stay here. Thanks a lot for inviting me. Thanks to Chris in absentia. And I feel like I can be very informal here as I'm sort of actively collaborating with about half the people in the audience and have known people here for a lot of years. It's always exciting to come back to the Brigham and give a talk in the Bornstein Auditorium where I went to so many grand rounds while I was here. So I'm going to update you on some of the projects of the Inner City Asthma Consortium that I've been involved in. And actually, several of you in the audience are collaborators in this work, so sorry to bore those of you who, 2 or 3 of you who know all about this, because you've actually been involved in it. But first, a little bit of a history when we're talking about the Inner City Asthma Consortium, or sometimes people just refer to them as the NIAID Inner City Studies because they've had different acronyms over the years. The first of these a study I was not involved in, called the National Cooperative Inner City Asthma Study, approximately 89 to 94. Some of my dates could be a little bit off. Susan Redline was an investigator in this. She's here at the Brigham. Many of you know her. And the National Cooperative Inner City Asthma Study did a cross-sectional study which characterized inner city asthma, sort of an epidemiologic clinical investigation. They also, in the NICUS, did an asthma counselor intervention, a randomized clinical trial of an asthma counselor intervention. That was someone, the asthma counselor was someone with a background in social work that they trained to know about asthma and to become an effective asthma educator in case management and work with the families of these inner city families of asthmatic children. And that showed a clinical benefit of that asthma counselor intervention. Then the first of the phases I was involved with was the Inner City Asthma Study, approximately 1995 to 2001, co-funded by the NIEHS. Diane was involved in this. Environmental intervention and physician feedback randomized clinical trial. So that was basically a single study, which was a randomized clinical trial with a 2x2 design. And we looked at an environmental intervention based in the home for inner city kids with allergic asthma. And there was also a physician feedback intervention. And I'm not going to go into these today, other than to just mention a couple of things about the environmental intervention in a minute. The next phase was now called the Inner City Asthma Consortium. And now this was different than the ICAS. The ICAS was basically a single study that we did, funded by NIAID with co-funding by NIEHS. ICAC and subsequently have just been funded by NIAID. And now this consortium undertook a number of different studies. So the ICAC does not refer to a study, but a consortium undertaking several studies. And we did a randomized clinical trial of exhaled nitric oxide to titrate asthma therapy to see whether that improved outcomes. We did a randomized trial of omalizumab for inner city kids with persistent allergic asthma. It's called the ICATA trial. I'm going to mention a little bit about that. We did some studies of sublingual cockroach immunotherapy, looking at biomarkers to decide if this was going to be a feasible form of therapy for inner city kids with allergic asthma, cockroach allergy being such an important factor there. And we initiated the URECA birth cohort epidemiologic study that I'm going to present to you some of the findings of today. So all of these studies were done in the framework of the Inner City Asthma Consortium, phase 1. Now, then phase 2 of the Inner City Asthma Consortium, we usually just refer to as ICAC 2, it basically just wrapped up within the last couple of months, that contract period. And we did a randomized clinical trial of omalizumab administered over a short part of the year to see if it would reduce exacerbations in the fall. And I'm going to talk about that in a little bit of detail later. We did some other studies that I'm not going to talk about today, characterization of difficult to control intercity asthmatics versus easy to control asthmatics, to try to understand what is the difference between these groups immunologically, physiologically, in terms of their home environment. We call that the APIC study. I'm not going to talk about that today. We did another study of the epigenetics of asthma in collaboration with David Schwartz out in Denver. He's one of the basic science, or one of the bench science sites for the Intercity Asthma Consortium. And we obtained blood and nasal epithelial brushings from kids with asthma, allergic asthma and non-asthmatic controls, all inner-city children, all African American in that case, to look at the epigenetic profiles, basically genome-wide methylation profiles of blood and epithelium in those kids. And of course, we continued to follow the URECA birth cohort that had been recruited in the prior phase. They're not babies anymore, and so it's been a blast following these kids who are now turning 9 and 10 years old. And then ICAC3 has recently been funded by NIAID, so that is just getting going. The studies that will be done as part of ICAC3 are to be determined. When we put in the application, we had to propose a number of studies that would be examples of the kind of studies we might do, but with the understanding that NIAID and further deliberations of the steering committee might not in fact decide to pursue those studies. So we have a number of ideas that things will probably go ahead, including some work on cockroach immunotherapy, but the details of exactly what will be done over the next 6 or so years as part of the ICAC3 contract remain to be worked out in detail. So let me tell you a little bit about the work we've done over the last few years, focusing just on a few topics today. Bugs, by which I mean cockroaches and bacteria, immunotherapy, and some of the omalizumab work we've been doing. So this is a slide from the NICUS study that I was not involved in, from a 1997 New England Journal paper. And those of you who work in the field of environment and inner-city asthma and so forth will recognize this slide. It's shown a lot. Basically, cross-sectional data in which these kids with inner-city asthma in 6 or 7 cities around the country had their homes characterized in terms of the level of cockroach allergen in the dust. And they had allergy skin testing to see if they were allergic to cockroaches. And then via questionnaire ascertainment, it was determined, how often they'd been hospitalized and how often they'd unscheduled medical visits for asthma attacks in the prior year, in the past year. And now group 1 and group 2 are kids who are not allergic to cockroaches. The group 2 kids, however, are exposed to cockroaches, but they're not allergic to cockroaches by skin testing. Group 3 and group 4 are the kids who are allergic to cockroaches by skin testing, but they have low or undetectable levels in group 3 and high levels in group 4. So again, group 4 is the kids who are sensitized to cockroach by allergy skin testing and who have high levels of cockroach if you vacuum up the dust in their home. The basic finding here, and this was the key finding of this paper in the New England Journal, was the kids who are both sensitized and exposed to cockroach allergen among inner city kids with asthma had higher hospitalizations and higher total number of unscheduled medical visits for asthma during the previous year. So this has become a very influential figure that is often referred to, and people talking about the importance of allergens in inner city asthma. And it's one that has motivated some of the future work of the Inner City Asthma Study subsequent to this and the Inner City Asthma Consortium, as I'll explain. So following the NICUS study, which led to the finding of the previous slide, the next study in this sequence was the Inner City Asthma Study, or ICUS. This was, I mentioned before, a randomized clinical trial of an environmental intervention and a physician feedback intervention. The 2 interventions were done with a 2x2 factorial design, and it turned out that the effects of the interventions were independent. They didn't modify each other. So we published them as basically separate results, as if they had been done as separate trials. And this New England Journal paper we published in 2004 presented the results of the home-based environmental intervention among urban children with asthma. And I'm just going to present a few slides from that to remind us what the findings of it were and how that motivated the future studies that we did and the thinking of the consortium. So what was the intervention? Well, the intervention included education of the families about the roles of allergens and irritants, including smoking and so forth, but a purely environmental intervention. In other words, our teams going to the home of these asthmatic children had no training in the clinical aspects of asthma and were by protocol not even permitted to discuss it. There was no discussion of inhalers and the need for adherence to your medications. There was no discussion of action plans and what you should do if you're having wheezing. This was simply people with no medical background that we trained to administer an environmental intervention related to asthma. So there was that education piece solely on environment, and we provided HEPA vacuum cleaners, and we provided HEPA air cleaners and allergy-proof encasings for the pillows, mattress, and box spring. For those who had cockroaches and positive cockroach allergy, we provided a year's worth of Terminex services. This is the Terminex guy coming in, doing the gel baths and stuff. So it was a comprehensive, multimodality environmental intervention that dealt with allergen avoidance and reduction, dealt with irritants, dealt with smoking, provided education, provided services, provided supplies. And what was the bottom line of that? Well, this is the key slide. Our primary outcome for this RCT was the number of symptom days, asthma symptom days per 2 weeks, which we would ascertain periodically. Every couple of months, we would do a computerized telephone interview and ascertain the frequency of asthma symptoms. And during the intervention year, the intervention group experienced a reduction in asthma symptoms and maintained that for the follow-up year. Now, in the follow-up year, they got to keep the vacuum cleaner and the HEPA filter, but we were no longer visiting their home. We were no longer doing education. We were no longer giving them Terminex services if they were cockroach allergic. And yet we saw that there was some, a continued reduction compared to the control group in asthma symptoms. So our interpretation of this was that our multimodality intervention reduced asthma symptoms. There was also a signal for reduced asthma missed days of school related to asthma and emergency visits, although it was not powered for emergency room visits or hospitalizations. So a positive result indicating that our multimodality intervention was efficacious. But now the way we designed the study, we could not say what part of this intervention was efficacious because, as I mentioned, the multiple modalities and multiple environmental exposures were impacted by this. The HEPA filters would deal with environmental tobacco smoke. The allergen reductions would include both cockroach and dust mite. We educated people about avoiding irritants and sprays and so forth. So a number of aspects of this, it would be impossible to say which aspect of it was responsible for the reductions in asthma morbidity. We did, however, measure allergen levels pre and post the intervention. And for BLA-G1, one of the major cockroach allergens, and for DUR-F1, one of the major dust mite allergens, we saw that there was a relationship between the reduction in asthma symptoms and the reduction in allergen. All right? And though you can see the change here is this is actually a Pearson correlation, I believe, and it's showing the p-value indicating that the more we brought down the allergen levels of cockroach and dust mite, the more the symptoms were reduced. Now, that doesn't prove causality because it could be simply that these reductions in allergens are a marker for having received the intervention and for the intervention having been successfully implemented in your home. Maybe these relationships are still indicate, most of the reduction in morbidity could have been due to the HEPA filter, but these reductions in allergens are just a marker for a successfully implemented environmental intervention. So although this may suggest that the degree of reduction in these indoor allergens was associated with increased reduction in symptoms, we can't be sure whether these were really what drove the reduction in morbidity or they're simply markers for some other aspect of the intervention. But again, this is still influencing our consortium and the thinking of NIAID about the importance, potential importance of cockroach allergen in this population as an important driver of allergic asthma. So that led to, in the ICAC, that was ICAS again I was just talking about. So in the next phase, the initial ICAC phase, Inner City Asthma Consortium, that led us to have one of the focus of activity, one of our foci of activity, to be on the development of cockroach immunotherapy, with the goal of being able to desensitize inner city cockroach allergic children, desensitize them to cockroach allergen in the hopes that that would lead to an improvement in asthma. And as we approached that, there's been a lot of interest in sublingual immunotherapy as opposed to subcutaneous immunotherapy for many reasons. It could be potentially safer, could be implemented in the home without weekly visits to the allergy clinic to have injections. And so a lot of appeal of sublingual immunotherapy, which at the time we were undertaking these trials had been shown to be efficacious in certain allergies like grass allergic asthma and so forth. And the sublingual immunotherapy, as you know, is being used in Europe, where they, and the immunotherapy, their approach to immunotherapy tends to be a little different in Europe than in here, than in the United States. But they have been using some sublingual immunotherapy over there. And we developed a program to look at this and try to decide if this could be a way forward with inner city asthmatic children. And so I'll show you a paper we published in Journal of Allergy and Clinical Immunology last year that presents the results of three little studies that were done as part of the Inner City Asthma Consortium. So the first of these was, had the acronym SLIT, which I think just stood for sublingual immunotherapy. These were just little acronyms we gave them within our consortium so we could keep track of them. And this was simply a short-term, 2-week, uncontrolled, open-label, single-site study in which 27 children and adults were given sublingual immunotherapy with cockroach allergen just to see if it was going to be tolerated, to make sure people weren't going to have horrible allergic reactions and start vomiting and so forth. So it was just an initial 2 weeks of, per subject just to see what happened. You can see the concentrations of BLA-G2 and BLA-G1. The immunotherapy extract included both of those cockroach allergens. And so that was the first trial. That led to the BioCSI, which stood for Biomarkers of Cockroach Sublingual Immunotherapy. This was a multi-center study, one that we participated in over at the Boston Medical Center site, in which 54 adults now were treated for 6 months with daily sublingual immunotherapy with the cockroach extract. And our primary outcome here was biomarkers. We were looking for a change in the cockroach-specific IgE level. Those of you familiar with immunotherapy and sublingual immunotherapy will realize that though having high IgE to an allergen is a bad thing, it's what mediates the allergy, when you start giving someone immunotherapy, initially the IgE level rises. Then they go on to develop desensitization and the beneficial clinical effect. But as a biomarker that you're just responding immunologically to the immunotherapy, you first develop this rise in IgE. So that was something that was considered to be our primary outcome, but we also looked at blocking antibodies, I'll mention later. So those are two of the studies that were done. And then two more, sublingual immunotherapy, BioCSI-2, is basically just now looking at children rather than adults. 89, this is a double-blind, placebo-controlled trial as well. 2 different doses, high dose and low dose extract. Again, looking for change in cockroach-specific IgE in children this time as opposed to adults. And then finally a subcutaneous immunotherapy trial, open label, single site. Again, this is just looking for adverse events. Now, in clinical practice, sometimes allergists put cockroach extract into the mix of immunotherapy that they're giving people today. However, it really has not been, those extracts have not been standardized to a level that the NIAID could feel comfortable launching a trial in inner city asthmatic children with cockroach extract, despite what clinical allergists may be doing in practice. And that's part of the thinking that led to the need to sort of start from scratch in doing trials and studies of subcutaneous immunotherapy with cockroach extract so that we could develop some scientific basis for knowing what's the dose that should be used, how efficacious is it, et cetera. And so that has led to sort of a development program on subcutaneous as well. Well, here's just some of the results from this 2013 JACI paper. When you look at now this is in the bio-CSI study that we participated in over in the BMC site, adult sublingual immunotherapy with the cockroach extract. Well, when we look at the cockroach-specific IgE response, we really see a little bit of bump with the extract compared to placebo, but not that much and not that consistent across all the people who are getting it. When we looked at the IgG4, we saw no response there. Now, in contrast, the adult subcutaneous immunotherapy trial that we did, we saw a little initial bump in IgE, then came back down, so not necessarily so impressive there. But for the IgG4, a much more robust picture of having some immunologic reaction to the subcutaneous immunotherapy than to the slit. And when we looked at the anti-IgE complex binding to B cells, and this was an assay that was done by Steve Durham over at, I think, Imperial College in London, to look for bio-CSI, the sublingual, we really didn't see any evidence at all of the development of blocking antibodies to the sublingual. So that was very disappointing. In contrast, the subcutaneous immunotherapy showed this expected and desirable decline in the binding to the B cells. So this indicated that there's some blocking antibody that developed in response to the subcutaneous immunotherapy, but we just weren't seeing anything like that for the sublingual immunotherapy. And that has led us basically to change directions away from the sublingual immunotherapy. So when we launched into this, there was a fair bit of enthusiasm that this might be a nice approach for inner city kids, and subsequently we've become disillusioned and have decided to abandon the sublingual, but are now interested in exploring subcutaneous immunotherapy to see if this could be an approach we might want to go in. So to summarize where we are with our cockroach immunotherapy development program as part of Inner City Asthma Consortium now, we found no safety problems, either for the SLIT or for the SCIT. They had safety profiles like you would expect. Immunotherapy is associated with some side effects, but we didn't see any worse side effects with this than you would expect for immunotherapy. The German cockroach sublingual immunotherapy induces some changes in specific IgE, but inconsistent. The subcutaneous immunotherapy, in contrast, induces an overall more substantial immunologic changes, especially IgG4 and the FAB inhibition. So the cockroach subcutaneous immunotherapy for roach-sensitized asthmatics is going to be a major focus for ICAC3 going forward. And that may ultimately, this has not been all decided, but that may ultimately take the form of a big multi-center randomized clinical trial involving all the ICAC sites for cockroach allergic asthmatics with immunotherapy. And so that's to be determined, but we're still a couple of steps away from launching that big RCT. I think there's going to be a little bit more single site work done, probably by Bob Wood down at Hopkins, in terms of getting the formula just right for what extract concentrations we're going to be using and so forth. Now, so I've been talking so far about the fact that cockroach exposure can aggravate asthma among sensitized asthmatics. So these are kids who already have asthma, they're already allergic to cockroach. How are we going to do secondary prevention to prevent them from getting asthma attacks? We tried the allergen avoidance. We think that may work with a comprehensive allergy environmental intervention. The cockroach immunotherapy is an area we're pursuing as well. All of this is, of course, a very different question than one of the other questions that we're interested in, that many of you in the audience are interested in, which is, does cockroach exposure contribute to the development of childhood asthma in inner city children? In other words, primary prevention implications. Things that aggravate asthma among kids who are already sensitized and have asthma may have totally different effects in early life exposure in terms of the incidence of asthma. So timing is key here. And I'm going to tell you a little bit about one of our other major projects then within Inner City Asthma Consortium, which is the URECA birth cohort, and trying to study risk factors for the development of asthma. And Diane has been involved in this from the very beginning. This is a paper from one of Diane's, a table from one of Diane's studies with Gus Luton, who was the lead author, and this is from Diane's home allergen study from 2002. And it's a paper in which they looked at, in that birth cohort recruited here at the Brigham, the relationship of cockroach allergen exposure and all these other allergens to the development of recurrent wheeze at age 3. And now Diane's cohort was recruited here at the Brigham and included a minority of the members of the cohort were women who would have been eligible for our study. A minority of the families were from low-income inner-city neighborhoods, but there were some. And so when Gus and Diane and the group looked at BLA-G1 or 2 allergen with respect to the development of recurrent wheezing at age 3, and these are allergen levels determined early in life, shortly after birth, they used as a dichotomous cut point to develop these odds ratios homes with levels less than 0.5 units per gram of dust versus greater than 0.5 units per gram of dust. So I'm going to show you in a minute, this cut point is much lower than the levels we see in the inner city homes in ICIC. And what they found, though, was that the homes that had a cockroach allergen level above that threshold had an odds ratio of a little over 2 for the development of recurrent wheeze, suggesting that early life exposure to cockroach allergen could be a risk factor for the development of recurrent wheeze. This was, more striking. I mean, it was kind of null for dust mite, and dog was potentially even protective, and there's been other literature to suggesting that dog allergen might be protective. So this is one of the early papers suggesting that there might be a role for cockroach allergen in the causation of asthma in the first place. So not just exacerbating, but actually leading to the development of asthma. So this became a major hypothesis for us to test as part of the URECA birth cohort. We published in just this year in Journal of Allergy and Clinical Immunology the outcomes of the URECA birth cohort at 3 years of age, and what were the predictors of recurrent wheeze at 3 years of age. You can see Diane's part of this as well, and Roz, who you all know. And what we see is different, and I'll go over that with you. So the URECA birth cohort involves children recruited here in Boston, at Boston Medical Center, WashU in St. Louis, Johns Hopkins, and New York City at Columbia University with Meyer Catan. So 4 sites, we recruited moms who either the mom herself or the father of the expected child has a history of asthma or allergies, similar, I think, to the home allergen study that Diane had done earlier. So kids with a higher risk of asthma and allergy based on parental history. And then to get into the study, they not only needed for the mom to agree to be in the study and fill out the questionnaires while she was pregnant, but then we had to get cord blood. And once the child was born, not prematurely, and we got umbilical cord blood, then the child was considered enrolled in the study. And we enrolled just a little over 500 children meeting those criteria into the study. And this is a follow-up at age 3. Now, we had 467 kids who were still being followed by age 3. Those I'll show you when I look at individual analyses due to missing data from dust and so forth. Most of the analyses aren't 467 children. Just a few characteristics of the kids. And I just wanted to point out that it's 71% black, 20% Hispanic, and 9% other. So this is almost all minority children. Household income less than $15,000, 69%. So to be eligible for the study, you had to live the family had to live in a census tract with more than 20% of the families below the federal poverty level. So inner city kids, largely minority. And number of smokers in the home, I guess that means 0.93, so nearly a smoker in every home. Yeah. Okay. And now, some of the characteristics, what were our levels of cockroach allergen? Well, remember Diane's dichotomous cut point was greater than or less than 0.05. Well, our mean was 0.93. This is the interquartile range. So our 25th percentile was 0.20. It went up to 6.30. So you can see in terms of micrograms per gram of cockroach allergen per gram of fine dust, much higher levels than on average we're seeing in the home allergen study. And then same for BLA-G1 in the living room, BLA-G1 in the bedroom. So high levels across the board of cockroach level, of cockroach allergen. Now, this looks at associations between aeroallergen sensitization to a specific allergen at age 3 and the living room exposure to that allergen. So in other words, you'd sort of hypothesize, and certainly other studies have shown, that if you're to become allergic to an allergen, you sort of need to be exposed to it. So we would expect there to be some correlation between being exposed to an allergen and becoming allergic to it. And this is, again, sensitization at age 3. And we did skin testing and we did specific IgE. Well, it turned out that when we look at sensitization at age 3, it's not really that related to what your exposures were in the first year of life. We did a home visit at around 3 months of age. Sometimes they would be a little later than that, but early in the first year of life, we did a home visit. And whether you were sensitized to a specific allergen at age 3 wasn't so much related to what the measured dust level in your home was at age 3 months. But when we looked at cumulative exposure up until your 3rd birthday, then whether you were sensitized was significantly associated with whether you'd been exposed. So the point I'm making there is that the key time for developing allergic sensitization to an allergen may not be at 3 months, but it may be a little bit later, the exposure that's occurring later. And that is perhaps logical because most kids, don't develop aeroallergen sensitization when you're 3 months old or 6 months old. It tends to develop a little bit later, and maybe the later exposures are what's key there. But exposure is certainly associated with developing sensitization to an allergen. Furthermore, if you are sensitized at age 3, you're more likely to have recurrent wheezing at age 3. Well, this is obvious to be expected. We know that allergy is associated with asthma. That we would be shocked if we did not see that. So again, adjusted for race and sex and perceived stress scale and environmental tobacco smoke, you can see all these significant or nearly significant odds ratios. If you're sensitized to things, if you're allergic, you're more likely to have recurrent wheeze at age 3. So now what's the next step? We were kind of expecting that if you're exposed to allergens, then you will be more likely to wheeze, that exposure to allergens may be a risk factor for the development of wheezing. But in fact, what we see is the opposite. When we look at early life exposure to allergens, such as cockroach, all right, again, in the first year of life, at around age 3 months, and we look at the association between that and recurrent wheezing at age 3, it seems protective. The odds ratio is 0.59. The higher the level of cockroach exposure in that first part of life, the less likely you are to have recurrent wheezing at age 3. And same for mouse. So when we saw these results, we said, oh, well, it's a programming error. Have our programmers go back. They just flipped a digit. No, it's real. And it's a robust finding in our data set. And we can't adjust for anything that makes it go away. The higher the exposure to cockroach and mouse in early life, the less likely you are to have recurrent wheeze at age 3. So we obviously were very intrigued by this and wanted to sort of look at it in some different ways and try to understand it a little bit better. So here are these 3 allergens, roach, mouse, and cat, and we developed, and we looked at it, well, what's the relationship of the probability of wheezing at age 3 years according to the number of allergens to which you have an exposure that's above some set threshold, a high exposure. And it seemed that the larger the number of indoor allergens like this you were exposed to at 3 months, progressively less became your risk of developing recurrent wheeze by age 3. So if you were exposed to all 3 of these things, you had a much reduced risk of developing recurrent wheeze by age 3. So this was very interesting indeed. We wondered, well, maybe it's different for kids who are sensitized to allergens versus not. So here we look at early life exposure and recurrent wheeze at age 3. And this is now exposure index for year 1 by sensitivity. So the pink is sensitized kids and the blue is non-sensitized kids. And it was at year 1, the year 1 exposures where we see the biggest effect, right? And it didn't matter whether you wound up sensitized or not sensitized, that those exposures in the first year of life, the greater the exposure index, the less your probability of recurrent wheeze. The exposure index here is you could get a 0 through 3 based on the degree of exposure for the 3 allergens I mentioned before. So if you had the highest degree of exposure to all 3 allergens, cockroach, cat, and mouse, then you got a 3 for each of them, and you had an exposure index of 9. So it's just a little index we made up that ran from 0 to 9. And the greater your exposure, the less your probability of developing recurrent wheeze at age 3. And it didn't matter whether you wound up a sensitized kid or a non-sensitized kid. Although there was a suggestion of a similar relationship, not as strong if you looked at the exposures later on in life. So we wanted to try to understand, well, what might be explaining this? We looked at endotoxin. Our first thought was, well, maybe it's endotoxin. Maybe the homes with the higher degrees of cockroach and cat allergen and mouse allergen have more endotoxin in them. And that's the explanation, because a lot of interesting work has been done, including some by Diane's group, looking at the relationship of endotoxin, and that perhaps early life endotoxin exposure revs up your immune system and in a different way and protects you from developing allergic wheeze. But we had measured endotoxin in the first 3 months, in the first year of life, and adjusting for that didn't make this go away. It wasn't explained by endotoxin. Well, as part of the Inner-City Asthma Consortium round 2, we brought in a couple of bench science sites into the consortium that had not been previously part of it. And one of those bench science sites is that of Sue Lynch and Homer Boucher out at UCSF. And they're very interested in non-culture methods for quantitating the microbiome and measuring, the spectrum and the richness of bacteria in the environment using these 16S ribosomal RNA phylochips and all the bioinformatic analysis that goes with it. These data are extremely voluminous and extremely complicated, and this a whole bioinformatics approach is developing for analyzing these data. So unfortunately, this was not part of our study when we first started the Inner-City Asthma Consortium, when we first started the URECA study. So it's not that we had not put aside dust for everybody to have these phylochip measurements done. This was a technology that became available later, and then especially became part of our consortium later when Homer and Sue and their group were brought into the consortium. But we were able to, using dust that we had available, start with a sort of a case control type, nested case control study within the context of the study we've just done that I just told you about. So what we did is we took 20 of the children I was just telling you about, whose data we've been discussing, took little subgroups, 25 kids who at age 3 have no wheezing and they're non-allergic by skin testing and specific IgE. 25 kids who are wheezing, but they're non-allergic. 25 kids who are allergic, but don't have recurrent wheeze. And finally, 25 kids, approximately, who are both having recurrent wheeze and they are sensitized to indoor allergens by skin testing and or IgE. And so we did this sort of, as I said, a sort of a nested study with these groups of 25. I think it's actually 26 in each of these groups. And we did the phylochip on them, and we looked at the richness of bacteria in this, the dust from 3 months now. So we had enough dust in the freezer from 3 months that we could do the phylochip on that dust. We're looking at the microbiome within the homes of the kids. And we're looking at microbial richness. Now, microbial richness is basically the number of different taxa are available. So if increased richness means there's more bacterial taxa in the specimen. Reduced richness means there's not as many bacterial taxa. So again, we're looking at this color code here is orange means M high, so lots of microbial richness and high allergen levels. Blue is lots of microbial richness, low allergen levels. Green is low microbial richness, high allergen levels. And finally, purple is low microbial richness, low allergen levels, okay? And basically, a key finding perhaps is those who are atopic and wheezing, all right, have a very low orange bar here, okay, very low levels of, or rather smaller percentage of the homes, and these are percents of the homes, I should say, these numbers, percent of the homes. A small percent of these homes of allergic wheezing kids have high allergen level and high microbial richness, okay? A larger percent of the homes of these kids who are allergic and wheezing have low microbial richness and low allergen level, or low microbial richness and perhaps high allergen level but low microbial richness. So this was just one of the analyses we did as part of this look at the microbiome. And again, it's just based, and these are statistically significant differences in the proportions. It's only based on 104 of the larger group of kids. So I consider it sort of preliminary and a discovery sort of analysis, but at least it suggests that one possible explanation for the findings I just showed you, which seem kind of paradoxical, is that in fact these homes with high allergen levels have high bacterial richness. And that's why the kids have less recurrent wheezing, not because of the high allergen levels per se, but the high bacterial richness in many of those homes may lead to some different priming, different development of the immune system, or some other effects on the airways that lead to less recurrent wheezing. To summarize, indoor allergen exposure at 3 months was associated with reduced risk of current wheeze at 3 years, even though, as expected, allergic sensitization by age 3 was associated with recurrent wheeze. And the sub-study that I just went over suggests that low bacterial richness and allergen levels at 3 months predicts recurrent wheeze at age 3 years. The protective bacteria, by the way, those bacteria that seemed protective based on this analysis, were chiefly Bacteroides and Firmicutes, two taxa of bacteria. And some of the levels of these Bacteroides and Firmicutes bacteria were positively correlated with the levels of BLA-G1 and MUS-M1, the major mouse allergen. So now we have this sort of complex interconnectedness that, high cockroach levels are associated with high levels of certain bacteria, and those high levels of bacteria and the increased richness of the bacteria that may be associated with having cockroach infestation may be protective. So we've got these dueling things going on potentially, bacteria associated with cockroaches that may be protective, while the allergens associated with cockroaches may be leading you to become sensitized to those allergens, especially as you continue to be exposed to them in the 2nd and 3rd year of life. So I think it's getting rather complicated. So I'm going to switch gears now back to what do we do about allergic kids who have asthma and they're allergic. We're out of primary prevention now into secondary prevention. Is there something we can do to prevent asthma attacks among allergic asthmatic kids in the inner city? And one of the things that there's been a lot of interest in is omalizumab, because omalizumab, or humanized recombinant anti-IgE, has been shown to be efficacious for allergic asthma. Although we've previously done the ICUS intervention and show that perhaps there is a possibility of doing an intervention to reduce home allergen exposures, it's complicated to do that. It's not completely cheap to do that, although it's cheaper than omalizumab. And in any case, we're always looking for different approaches that might be good for inner city kids with allergic asthma. So the consortium decided we should see, especially since this population may have a lot of disease driven by cockroach allergen exposure, and it might be difficult to completely eliminate exposure to cockroaches, even if we intervene in their own home. What about other settings like school that Wanda studies and other people's homes and so forth? So can we try omalizumab, and might that have a particularly good payoff in these inner city kids with asthma, allergic asthma? So this paper we published in 2001. Lead author is Bill Bussey, who's the overall PI of the Inner City Asthma Consortium out in Madison, Wisconsin, a distinctly non-inner city site. And we call this study the URECA Study. And I'm just going to show you a few slides from the URECA Study. And these were kids with a mean age of around 11, as you can see, again, all from low-income urban communities in the participating cities, and mostly minority patients, as you can see, as with all of our studies. And we randomized them to either get omalizumab or placebo over the course of a year. And during that year, we managed their asthma ourselves. And we managed it rather aggressively according to NIH guidelines-based care, with a step-up program that went all the way from low-dose Flovent to high-dose Advair. We would see the kids every 2 or 3 months or so, and we would assess their symptoms and their lung function, and we would step up or step down therapy as warranted. So we're doing good aggressive asthma care as their baseline, and to which we added omalizumab or placebo. And this table from the paper summarizes some of the effects. So asthma-related symptoms, this is the number of symptom days in the 2 weeks preceding the visits, averaged over the course of a year. And so we reduced symptom days by about a half of a day of symptoms per week. We reduced exacerbation, the number having one or more exacerbations during the year, from 49% to 30%. And we reduced missed school days. When you look at the phase 3 randomized clinical trials that led to the approval of omalizumab, its effect is it approximately cuts exacerbations in half. That's basically the omalizumab effect in a nutshell. And we had roughly, going from 49% to 30%. So, we were in that ballpark approximately of approaching a reduction of exacerbations in half. So we saw that effect, positive trial. It works in inner city asthmatic kids. It works about the same as in all allergic asthmatic kids with perennial allergen allergy. But a couple of things we noted about the results that were a little bit unexpected. We expected that the effect of omalizumab wouldn't really become apparent for a few months. So when we designed the trial, first there was a run-in period in which we kind of got their asthma under control with conventional meds, started the omalizumab versus placebo, and then by our original design, we considered this first 12 weeks to be a wash-in period because we weren't expecting that we would see a real improvement in outcomes that soon. But in fact, this was 0 is randomization day, and by 1 month later, we were already seeing a noteworthy and statistically significant reduction in asthma symptoms in the omalizumab group. And then overall, over the course of the year, it stayed a significant reduction in morbidity. So this was a surprise to us and very interesting that, you could see this beneficial effect of omalizumab pretty quickly, even by the 4-week visit. The other thing that we noticed had to do with seasonality. When we looked at the days with symptoms, this is symptom days per 2 weeks, and we plotted it over the month of the year. As expected in the fall, kids go back to school and the symptoms increase. And in the omalizumab group, that increase in symptoms seemed to be reduced. So the fall worsening of symptoms seemed to be reduced by omalizumab. Even more strikingly, when you reach the fall every year and the kids go back to school, you reach the viral infection season, you get an increase in asthma exacerbations. And we saw that very clearly in our placebo group. But the omalizumab seemed to abrogate that expected fall increase in exacerbations. So this was very intriguing to us that the effect happened pretty quickly, and it seemed to eliminate this fall peak in exacerbations. And that got us wondering whether it might be reasonable to consider an approach for some kids with asthma where we use omalizumab only during part of the year rather than continually to maybe control costs, reduce inconvenience of the child coming in for these bi-week, every 2-week or every 4-week shots throughout the whole year. Could you use omalizumab in a more targeted period of time? So like in the summer when the kids do better, not be giving it to them, maybe just focus on giving it to them just before the school season. And that led to then one of the big RCTs that we performed as part of ICAC2, the contract phase, which is just completed. And we've recently completed data collection for this study, which we call the Preventive Omalizumab or Step-Up Therapy for Severe Fall Exacerbations, or the PROSE study. And the primary objective of this trial, as I've written here, is to compare the efficacy of 3 different treatments when used for 4 to 5 months, starting like in around July, so at least 30 days before the back to school. And those treatments were omalizumab or a boost up of inhaled corticosteroids. So you're normally on Flovent 100 twice a day to control your symptoms, but school's about to start, so I boost you up to Flovent 250 twice a day. A boost up in inhaled steroid or placebo. When added to NAAP guidelines-based care, to see whether to compare the efficacy in reducing fall exacerbations in inner-city children and adolescents with persistent allergic asthma when initiated 1 month prior to the start of the fall viral season. So again, using an approved drug, omalizumab, but in a different way, rather than just starting it and committing the child to be on it year-round, to just using it seasonally. And by the way, our study populations go down to age 6. So in the United States, as you know, it's only approved age 12 and higher. And in our previous ICATA study and in this PROSE study, we begin with kids down to age 6. Now, here's our study design in a nutshell. You can't see this, so I'm going to blow it up on the next 2 slides. But just so you can see the whole thing, we have a run-in phase of really 6 months during which we're just managing their asthma. We're not starting the omalizumab. We're managing their asthma according to NIH guidelines with a step-up and step-down algorithm that we designed to mirror the NIH guidelines. And we bring them into the study, you know, by at least, say, January or so that we have a full 6 months or so of managing their asthma and really try to optimize things. In all of our studies, we never want to compare our intervention to sort of a straw man control group of suboptimally managed asthma. So we always arguably make it hard by ourselves by having our control group have specialty managed, you know, NAP guidelines-based care. Then sometime in July, the kids get randomized and started on either the omalizumab or the step-up in inhaled steroid or placebo. And let me just in the next 2 slides make it so you can see that. So again, this was a challenging study in that we did this in 2 waves over 2 years. Since the intervention randomization therapy has to begin a month before school starts, we can't just do rolling enrollment throughout the year. So we've got to have these waves of kids who are all ready to go in July and start on the therapy. So we did that by doing it in 2 successive years, 2 waves of enrollment. So again, assumption of care, we manage them from January through July with good NAAP guidelines-based care. Then we begin the treatment period sometime in July, at least 30 days prior to the start of the school date. We begin either the omalizumab or the placebo, the boost-up inhaled steroid or the placebo, so it's a double dummy design. And then during the next 6 months, they're followed again every 2 months or so. We see them and we're adjusting their guidelines-based care while they're getting the study medication versus placebo. And then we see them for a couple more visits just to kind of wrap up there. And that's the design. So it's a full year or even a little more than a year that we're following them and managing them, even though for 6 months, and it's only a period of 4 months or so that they're getting the omalizumab versus placebo. And the primary outcome of this trial, which by the way, I'm not going to tell you the results of the study, the primary outcome is going to be the occurrence of 1 or more asthma exacerbations requiring systemic corticosteroid or hospital admission during the fall. And so in other words, the primary outcome will be, do they have do they need a prednisone burst or do they get hospitalized in that September to November period when we normally see the peak in asthma exacerbations. And the study has now been completed. The preliminary results were presented at the ATS this past May, and the preliminary results that were presented at the ATS look very positive, but I'm not going to actually present the results to you because it hasn't been published yet, and this is a webcast presentation. So this study is wrapped up and will soon be submitted for publication somewhere, and hopefully you'll be seeing the final results of that pretty soon. But a different way of using omalizumab in a unique population with a high prevalence of allergy to cockroaches and other indoor allergens. And that's one of the big studies that we accomplished during the second phase of ICAC. So let me acknowledge the NIAID, which funds the Inter-City Asthma Consortium. The NIHS co-funded the ICAS one, which was the second phase. Acknowledge all the ICAS and ICAC investigators, coordinators, and research assistants. And if I ever attempted to put up all the names there of even the investigators, it would overwhelm the slide. So I won't do that. And most importantly, acknowledge our study participants who are all as cute as can be and participate in all these studies. Thank you very much.
Thank you, George. It's an excellent presentation. I'm excited to kind of hear. We'll have to wait for the journal article to find out the exact, those of us who weren't able to be present at the ATA's presentation. So just start the discussion. We have a few minutes for discussion. Is there, this wasn't an inner city population. Do you have any pre-existing knowledge that you would think that type of intervention wouldn't work outside the inner city population?
Oh, you mean the pros thing?
Yeah. If it
yeah.
does in the end work. Right?
To me, it's completely logical. It kind of is based on the observation we made in the URECA study that the onset is relatively quick. Because if the onset is not quick, then if to get the benefit during the fall, you needed to start the therapy in March and then go through the fall, then you start getting close to the full year. So really the question comes down to, I think, do you get the benefit as quickly as we observed in the URECA trial? And I think that is probably the case. I'd be curious what some of the clinicians in the audience think about what they see as the quickness of onset of the omalizumab benefit. Elliot, you have any comments on that?
I think for the patients that it works and we have clear outcomes, you can see a fairly quick benefit. The problem is that we end up using it in a lot of patients where the symptom complex is much more nebulous.
Yeah.
So that it's harder in patients who have, just keep on getting exacerbations, and so it's harder to know if you're having 4 exacerbations a year, right? Then it's harder to know in a few months whether you did something or not.
Yeah, it's really true. I find the same thing, especially since the clinical trials tell us the benefit we're looking for is a reduction of 50% in exacerbations. And so, you review the past year's experience with a patient, and maybe he only had 2 exacerbations this year instead of 4, but it can be a little tough sometimes to know. Yeah. The other thing to point out about this work is that from a cost effectiveness point of view, don't misunderstand me. I mean, I'm not saying that we should put all kids on omalizumab before they go back to school. It's exceedingly expensive, as you know, and even if you're just doing it for 4 months, it's very inconvenient. You have to come to the doctor every 2 or every 4 weeks, get your shot for 4 months. It's exceedingly expensive. I think that in clinical practice, we tend to reserve omalizumab for our really refractory, difficult kids or adults, and I don't think that necessarily should change at this point. But I think this is our, the consortium's way of trying to understand immune-based therapies, and maybe they'll be more convenient and better immune-based therapies to emerge. But at least it gives us potentially another way to use omalizumab in those kids that we feel the need to use it.
Hi, George. Excellent summary of all the great work you've been doing in ACAS and ACAC. A couple of things, I think the population we see is a little different than Elliot's because kids have a lot of exacerbations, and I know it's not approved down to age 12, but sometimes in our bad cases we get it in kids younger, and I've noticed that the benefit is pretty quick. So it's pretty exciting data that you have. I was wondering about the PROS study. The placebo arm, you pre-treated them with a step up of ICS, or was it just placebo?
No, everyone as a baseline got good NIH guidelines-based care with inhaled steroids. Then there were 3 arms in the randomized component. You either got omalizumab, or you got a step up in steroid ICS dose before back to school, or you didn't get either. So it's 3 arms. Yeah.
George, great talk. So one comment, one question. The comment is that the rapid onset of action of omalizumab is not at all dissimilar from what the studies of chronic idiopathic urticaria have shown as well. So, that there's clearly pathways here that have nothing to do with depletion by GE from mast cells in the skin. My second question, or my question is, what's known about the gut microbiome of cockroaches and mice in these populations where you've seen this association, this nice inverse relationship between exposure?
I confess I know nothing about the gut microbiome of either cockroaches or mice, but perhaps Diane or Wanda does.
No. I don't know the details. I just know that both mice and cockroach love that.
have a lot of bacteria in their feces, and so allergen may be standing in for their bacteria.
Yeah.
They're
Yeah.
different too.
What-
One's
so
a mammal
what-
and one's a...
Right, and you can tell and the other thing I've learned from Colleen Cavanaugh is you can identify a creature by its microbiome,
Yeah.
which is what Wanda just said.
I mentioned in one of the slides that we saw a correlation between cockroach allergen levels and some of those bacteria that were identified in the fellowship. And a literature review showed that at least one of those Bacteroides class bacteria is associated with cockroach, and I think being in the cockroach microbiome. But I don't know any details beyond that, other than there was at least one literature citation indicating that that bacterium is found in cockroaches, one of those Bacteroides. Yeah.
And mice too, I think.
Well, yeah, I wouldn't be at all surprised, yeah.
Yeah, I think so.
Yeah. Matt?
I'm just curious, George, is there a prevailing opinion on how to summarize the allergen data? You know, there's data that suggests cleaning the house is beneficial and results in improved outcomes, and then your data that clearly shows that increased allergen exposure results in less wheeze.
Want to be born in a dirty house and then clean it up?
Yeah,
Is there a general summary that's being put out as an explanation for that?
well, I think that the thinking is, from conferences and I go to and things I read, is that there are aspects of the microbiome that are important where exposure to animals, including potentially having dogs and cats and cockroaches and the mice, if it's exposing you to a certain level of bacteria at that key part of early life, could be very beneficial in preventing allergic sensitization, preventing asthma, but then later on contribute to you becoming sensitized to those things. So I think the timing is absolutely key, and which is why there's no very simplistic approach to thinking, well, what do we recommend for homes? You know, should they be cleaner? Should they be less clean? Should they have pets? Should they have no pets? It's so hard to say. I think one of the most compelling ideas to come around in a while is that being born into a home with pet dogs might be protective. You know, I think there's some evidence to suggest that might be the case. Could you do an intervention to reduce asthma? Well, you could. I mean, it sounds a little far-fetched, but you know, you could get dust from homes with dogs or from barnyard environments like Erica von Mutis's work, and you know, you could in some way expose babies to that dust. You know, you could get some sort of thing and sprinkle it on their sheets or something. So it's not, it sounds a little far-fetched, but when you compare that to some of the other things that we do, like omalizumab that costs $20,000 a year, maybe, you know, I don't know.
The hour's getting close, but is there any last questions before we disband? Well, thank you very much, George.